The relentless pursuit of thinness is leading us to frailty and dementia as we age. You need to be an ass kicker. You need to be able to throw a toddler across the room. I mean, don't do that, but you need to be strong, because that's what's going to keep you out of the nursing home, keep you from falling, keep you functional as you age. Think about the next 30 years. Is the course that you're on, relentlessly counting calories and trying to be thin and low fat this and low whatever, is not serving you?
Hey, everybody, and welcome to the Paula Ferris Show. I am your host, Paula. And if you want to win a copy of Dr. Mary Claire Haver's book, it is the #1 New York Times bestselling book called The New Menopause, then make sure you are signed up for my personal newsletter at paulaferrisofficial.com. Dr. Haver was our guest last week, and she's coming back this week to answer all of your questions. But before we jump into the episode, I'm doing something a little out of my comfort zone. I've never done this before. I am selling all of my clothes from my past life in TV. If you don't know, I anchored GMA for many years. I co-hosted The View. I worked at ABC News and Network News for almost 10 years in New York City. And I'm selling my clothes. It's kind of weird to say, but I'm selling my clothes. They don't fit my lifestyle. They don't fit my body anymore. And that's totally fine. And I thought, you know what? It kind of goes along with this narrative of we're constantly told we're not good enough and skinny enough. And, I don't care anymore. I am content with where I am in my life. I don't need to go back. My body doesn't need to bounce back. So I'm selling off these beautiful clothes in conjunction with the Saved collection. I'll have all the details in the show notes, but you can get some of my really beautiful outfits for a fraction of the cost. And I am donating proceeds of my sale to the Boys and Girls Clubs of America. You guys know I'm a trustee of the Boys and Girls Clubs. So excited to do some good with this, but also to clean up my wardrobe a little bit and just say, hey, I'm content with where I am. Who knows? I might get back into TV one day, but I just need to move forward. And this is a big step in that process for me. So last week, Dr. Mary Claire Haver joined the conversation, and she did such a great job of explaining what's going on with our bodies and the loss of estrogen and what it does and how it leads to disease. And she explained that landmark study from 2 decades ago that freaked us all out about estrogen and hormone replacement therapy. And this week she is back and she is answering all of your questions. I've got to be honest, you're going to feel like you're drinking from a fire hose. So listen to this episode several times and make sure you're passing the series on to any woman in their 30s, 40s, 50s, and 60s who might be going through perimenopause or might have hit menopause and they're postmenopausal. I've heard from a lot of guys. Kudos to all the dudes out there listening to this who want to be supportive partners. My husband's actually going to join the conversation next week. But you guys, she does a great job of answering all of your questions. And thanks to all of you who DM'd me or sent me a message and said, I just need to get an answer to this. But she's going to tell us what's next in the process. So we know that we're losing estrogen. We know that doctors dismiss us because they don't learn about menopause or perimenopause in medical school. So they don't know what they don't know. So what is next? How do you get the help and properly advocate for yourself? What tests do you need to ask for? What questions do you need to ask your doctor? And how do you find the right doctor? Well, we're going to dive into all that and more as Dr. Mary Claire Haver joins us for part 2, answering all of your questions about perimenopause and menopause. And also stick around for my pinpoint, my key takeaways after the conversation. Okay, Mary Claire, are you ready for some Q&A? From the listeners? And
let's do it.
So a lot of questions. Kim and Crystal want to know, what is the starting point? Where do you even start with your doctor? And what kind of doctor? Is it your OB-GYN? Is it?
Maybe.
Okay.
So you only have about a 10% chance of walking into an OB-GYN or PCP, like internal medicine, family medicine clinician, and them being comfortable talking about menopause, let alone menopause educated. So here's my top tip. Go to the menopause.org website and look for a certified provider under their provider list. So they will list all of their members, but you want one that is taken the test, has done the study and taken the test. So you look for the check that says certified. It's not perfect. So Stanford Menopause, beautiful program, led by one of the scions of the menopause movement.
Amazing.
So she just started that. Ms. Medicine in Chicago, there's her MD, they're very menopause focused. They have clinics all over. And then on our website, I have testimonials from my followers. We have hundreds of this person did great menopause care. And we have them divided by state and city. So, I'm trying to help people find, providers, but I would definitely call ahead and ask, you know, how much training did you have? Are you comfortable prescribing HRT or having a conversation with me? And hopefully they'll be honest. What's the problem is that most OBGYNs or OB-GYNs will just list menopause in their list of things they take care of because they cut and pasted it from somebody else's list when they only had basically the bare minimum. And so unless they're menopause certified, it's going to be tough to find someone who really, really gets it.
But I like those questions. How much training have you had? And are you comfortable with HRT? That's great. And you can also do telemedicine, right? I mean, you wrote that.
And so there's some beautiful there's 3, and I have listed in the book, telemedicine companies that they don't pay me. They do not pay me to say anything. I am friendly with them, but they were entrepreneurs who saw a gap in the market, who went through horrible menopause, couldn't find care. And they were like, wait a minute, we can do this better.
Great. Amazing.
And form these telemedicine companies, physician-led, you know, who are doing the work and listening and taking care of patients. So, and providing access.
And that's menopause.org. Go to that website and that's where you can look for it. Okay. Tara says, and again, we addressed some of this in the previous conversation, but she wants to know what baseline blood work should I acquire to find a starting point? And again, she said doesn't know what to ask the doctor or where to start.
So in the book, I have a complete list of questions to ask your doctor. And I also have a list of blood work to ask for.
Okay.
So, and the blood work I'm talking about is not these crazy hormone panels and spending hundreds of dollars, spitting in tubes and taking saliva and urine, which really has not been shown to be clinically efficacious. We don't recommend that, you know, in the menopause. I'm talking about the autoimmune panels, nutritional deficiencies, the inflammation markers. You know, we want to make sure nothing else is going on that could be contributing to these symptoms that you're having. And so all of those are listed in the
process of elimination, right? So we can rule out some of that and then say, oh, no, categorically is a symptom associated with perimenopause.
I mean, I've diagnosed someone in menopause with lupus and with, you know, other autoimmune conditions. I diagnose anemia every day, vitamin D deficiencies, 80% of my patients, you know.
Yeah. Gina says, do your periods have to be irregular to be in perimenopause? And
no.
What about a NuvaRing? Okay.
Perimenopause begins far before your periods become wonky.
It's such a fun process. What about if you have a NuvaRing and you don't get a period? Like, how are you supposed to know?
So, you know, for people who iatrogenically, meaning medically induced no period from birth control or whatever, sometimes we have to take you off for a little bit to check levels to see if you're postmenopausal. You know, if I have someone on the monthly, you know, oral contraception and she's really symptomatic in her placebo week, you know, then that's really clear to me that, you know, the second we take the exogenous hormones out, she's having hot flashes, night sweats, joint pain, brain fog, you know, whatever it is. I'm like, okay, you're probably perimenopausal and we need to talk about changing up what we're doing here.
That's amazing. Okay. So let's talk about some of the symptoms. Jill and Janice both say, does it ever end? Jill says she's going on year 11, hot flashes, trouble staying asleep, dryness. She's like, well, this
the dryness will never go away without treatment. You know, the brain fog does. So there's 2 things that do tend to get better. The brain fog does tend to get better. The hormonal chaos, it begins in perimenopause. We completely rewire our brain and estrogen dumps out. And there's some recovery. It never goes back to where you were before without HRT, but you do see some recovery over time, unless you're on the Alzheimer and dementia spectrum. And then it just, you know, remember, dementia is a disease that begins in midlife with symptoms in the elderly. For most women.
Right.
So that does tend to get better. And the hot flashes do tend to get better eventually. How long does it take? Depends on the woman. People of African descent do tend to have longer, more serious, more life disruptive symptoms, but not to say that the basic, you know, Caucasian woman won't have horrible menopause. I did, you know, and I'm as fair as they come. It really is just so variable. But I know like Asians tend to have early, you know, later menopause and less symptoms. That could be due to some to diet. You know, all of this stuff is interconnected.
What is the range? Like it can last anywhere from X.
So we used to say, what I learned in school was 2 years. Now we know it's like 10, 15, 20, depends on the patient.
Oh my gosh. Okay. Well,
but your bones will never get better. Your genital urinary system will never recover and will only get worse. Your bones will get worse. Your genital urinary system, your skin will get thinner. You're drier. You know, all of that keeps going unless, you know, we intervene.
Okay. Most of the questions regarding the symptoms were about the weight gain. Sarah, Tara, Cheryl, Kim.
I wrote a whole book
like
about
30
that.
pounds. Yeah. So like, why do I just keep slowly gaining weight for no reason when nothing has changed? And how do you control weight gain?
So this is where I have the Seco people of the world and a lot of the people who are shaming women for menopausal weight gain, saying don't blame your hormones. I'm going to tell them to jump off a roof, because no changes in diet and exercise, you will have body composition changes. It is undeniable. So here's what happens.
Wow.
Everyone's gaining weight. And it's a very linear course for most of us, population based on age. So you get older, you gain weight. Okay, fine. Until somewhere in your 60s, and then we stop eating. However, what's happening in perimenopause? So age matched. Okay. So remember, 45 to 55 is still the normal range. So let's look at a 50-year-old. One's premenopausal, one's post. In the premenopausal woman, she has an average of 8% of her body fat is visceral. That's the intra-abdominal fat. Okay. And her muscle mass is at whatever percent. The postmenopausal woman has 23% of her body fat is visceral now. She triples it.
Wow.
And she's starting to accelerate her muscle mass loss. No changes in diet and exercise, simply due to hormone changes. How about that? That's what's happening. And when we start elevating our visceral fat, that fat is very biologically active and is pro-inflammatory. So now you're more inflamed. Now you're eating more. Now you're not sleeping as well. So everything about the menopause life is leading to the whole biopsychosocial, why we see women gaining weight. But, just saying it's you're lazy and you're not moving as much and you're eating too much is ridiculous. And that's all I was taught. So that's all about the Galveston diet.
Mm-hmm. I had a CrossFit instructor, and I don't do CrossFit anymore because I have joint pain. Tell me that he didn't believe that it had anything to do with menopause.
If the clinicians don't know, how would a personal trainer know?
Right.
So, and they're being taught, there's an entire multi-billion-dollar industry built around you're lazy, you need to work out more, eat less. We need to work out more and eat better. I don't want to say eat less.
Right.
Because most of us are not overeating through the transition. We are having these body composition changes because our hormones are changing. But we need to be lifting more weights for sure.
Right.
To keep our bones and muscle strong as we age.
Because we lose so much of our muscle mass.
We are losing so much muscle.
So how do we control the weight gain? Is it through estrogen? And I know you're probably going to say it's multifaceted.
It's multifactorial. I wish I could give you a magic bullet, but it's going to be a lot easier with HRT.
Okay. That's good to know.
You still have to do the things.
Yeah. It's not going to be, like you said, easy. There's no magic bullet for it. Sue Alice says, does it include teenage style mood swings?
Of course.
This time of life.
The mental health changes are huge. The anxiety, the depression, the irritation, the irritability, the loss of resilience to your normal day-to-day stress is huge and needs to be recognized.
Mm-hmm. Amy Elizabeth has 2 questions. This is funny. She says, I literally Googled, can my leg/hip pain kill me last summer when my joints ached so badly out of nowhere? Is that a symptom?
Yes, arthralgias are huge. So estrogen is a powerful anti-inflammatory hormone and gives us a level of protection. And we take it away, we pull it like we pull the tablecloth off the table, and our joints become inflamed. So we see more frozen shoulder, which is adhesive capsulitis. We see back, hip, joint pain out of nowhere. It used to wake me up from sleep. I would just roll over and I had no injury. We go get worked up. We go to the ortho. We do all this stuff. They're like, yeah, it happens to women at this age. And I'm like, make it stop.
Right. No, I've had shoulder pain so bad that I couldn't work out. I couldn't lift. I couldn't even sleep on my shoulder. And my knee was just going out. And my doctor was like, well, it looks like you might need a knee replacement. And he blamed it on a lack of cartilage, but other issues. And I'm like, I'm sorry. It can't just be falling apart. There's got to be more to it. And then Amy Elizabeth's follow-up question, she said, this is a great question. What constitutes a period as we track our year's time? Because going back to our first conversation, it's, you haven't had a period in 12 months, but what constitutes a period? What if you just
so in medicine, all vaginal bleeding is not a period. A period is a withdrawal bleed once the progesterone levels decline after an ovulation. How would you know that? Your periods, dysfunctional uterine bleeding could be too much, too little, too frequent, too heavy, too light, everything's off the table. It's just not that. It's different than what you used to live with. Right. And so you've lost the predictability. And for some women, it's hemorrhagic. So now they're dealing with anemia and blood loss and, all the things.
Okay. That's really, really a great explanation. And you mentioned this a second ago, Mary Claire, about the brain fog getting better and the forgetfulness, but you also said, what was it, like 20 or 25% of women are leaving the workforce because of it? But Holly wants to know, how can I improve the brain fog and forgetfulness? It's so frustrating. Is that hormone replacement therapy?
That can go a long
MHT?
way. But there's a great book. I was just turning around looking for the book. I have
Yes.
a zillion menopause books up here. Dr.
You
Lisa
can also send me the links if you want, and I could put them in the show notes, afterwards, if that's easier.
Lisa Mosconi wrote The Menopause Brain. So she's a PhD neuroscientist, and her whole life's work has been how female brains are different than male brains. And she started out researching why women get Alzheimer's more often. And they used to say it's because they live longer. Well, that's not true. It's because we lose our estrogen and it accelerates that course. And of course, there's genetic stuff. But Lisa does a lot of, like I do in the toolkit talking about nutrition and she really does a deep dive into nutrition, exercise, stress reduction, cortisol levels, and how that all affects the brain and what you can do and hormones to help with that.
Okay.
But my patients are coming back and like telling me they got their life back when they start
from hormone replacement. Okay. Can I ask a really dumb question? This is mine. Is it a pill? Is hormone replacement, or is it a
So no, it's a great question. So we have multiple delivery options of hormone therapy. We have oral and non-oral are the two main categories. So oral is a pill, but non-oral, I'm on a patch. So we have patches, creams, gels, the rings, that can go transmucosal vaginally compounded. You have creams, you have troches, you have pellets, you have all this stuff. For my patients and all of us in the Menopausal, we stick to FDA approved options for our patients. So it really depends. Each different method has different risks and benefits. So those are very nuanced conversations with your doctor.
You've said Menopausal twice. Is that like my posse is of the, like a menopause?
Yeah. So I have this friend group of multidisciplinary clinicians. So nurse practitioners who are women's health. We have cardiologists, we have psychiatrists, we have orthopedic surgeon, we have family medicine, we have internal medicine who've done like fellowships in women's health. And so we have bonded together and we call ourselves the Menopausal. The name just kind of was a joke and it stuck.
I love it.
And and we are Menopause 2.0, and we are not, weaponizing these guidelines against women. We are trying to get women educated so they can advocate for themselves.
Yes.
I mean, our big two prongs are teach women the real truth behind menopause and what it's doing to them and how she can advocate for herself with her clinician. And number two, we're fighting at the legislative level as well as at the boards. Like a lot of the Menopausal are on these, educational consortiums, American College, American Board of different subspecialties, fighting for menopause to have a voice because they really don't.
That's great. Okay. You're talking about it. You're doing something about it. I love that, the Menopausal.
So it's not just me. It's a whole group of us.
It's a group. And that makes me feel so much better. That should make anybody listening feel so much better too. Like you guys are actually doing something to change the game for us. And when it comes to hormone replacement therapy or MHT, how long before we'll start seeing get some sort of relief? Like, I want to go on it tomorrow.
So if it's hot flashes, we know within 3 to 4 weeks, 85 to 95% of your hot flashes will be gone. And sleep disruption, brain fog, most of my patients, by week 6, they're like, oh my God. Musculoskeletal pain, usually within the first month, you're like, I slept through the night. I didn't wake up. I can do X, Y, and Z. It's so much better. So I mean, it just really depends on the symptom and the severity.
But like 1 to 2 months, you should start seeing some improvement.
Yeah. And if you're not like seeing significant improvement by like week 4, I'm adjusting your dose.
Okay. Oh, that's good. So you can adjust the dose too.
Oh yeah, absolutely.
Okay, great.
Like any medication.
See, this is how naive. I'm just like,
it's okay.
I didn't know anything about it because it was so taboo, right? Because it was going to cause cancer. For so long. Janice says heart palpitations, and Salmo says things.
Yeah, one of the most common, it's a vasomotor symptom, the heart palpitations. Okay. And most cardiologists do not know that this is a symptom of menopause. And so women are getting these $1 million cardiac workups, going to the ER, being diagnosed with a panic disorder. And when it's just menopause. Right.
We have a whiny woman in room 4, right?
That's what it is. Room 4. Yeah.
That's what we're being reduced to. What about finger swelling and pain?
So swelling of the joints and hands is very, very common as well.
These questions are
extremities. Yeah.
Kristen she says she's so excited to have her question answered. She heard you on Mel Robbins' podcast, and she says she feels seen for the very first time. She's lived with it for years. It all makes sense now, My question is, how do you know if hormone therapy is the best option for you, and what symptoms do you usually recommend hormone therapy?
Because you're a female and you want it. So when you understand the risks and benefits for you and you make an informed choice, you are given ownership of your own healthcare and you make the best decision for you. But for most women, this is the best decision.
Okay. And she says, any symptoms you usually recommend hormone therapy for? I mean, I know there's okay, love that. Kelly, can you tame symptoms without HRT or med?
Yes, absolutely. So we have other pharmacology. Nothing works as good as hormone. It's giving you back what your body's missing. You know, all of these symptoms is your body waving a flag going, help me, I need estrogen. Okay. But say you choose not to do it. You're so freaked out about, you don't believe your doctor when they tell you the risks aren't, are overinflated, or you can't take it. We have absolute contraindications. What do we do with hot flashes? So luckily we have a whole set of pharmacology that can help. There's not great supplements that really help that well with hot flashes. So I would not go to recommend those, across the board. And maybe the occasional woman will find relief with turmeric or soy or something. But, I'm going into pharmacology with my patients, especially if it's sleep disrupting, life disrupting.
Okay. Nikki says, if you cannot take estrogen, and you just mentioned this, if you cannot take it due to blood clots or some sort of other so
then you don't want oral estrogen if you have blood clots, but you absolutely can do transdermal. It is not a contraindication for transdermal estrogen. She
says, is there an alternative treatment that you would suggest? And that's it.
So remember, estrogen is treating the root cause. Yep. And if you can't or won't take estrogen, then we have to go symptom by symptom. And then it gets really complicated. Then you may end up on 6 or 7 different medications for each symptom, instead of just estrogen, which would have treated everything. But that happens to patients. So we have to go there with them.
Christy doesn't want to do hormone replacement. So what if I don't?
But then I'm asking her why. Is it fear? I want her to make that decision based on facts and not fear.
That's good.
But if she just wants to, you can be healthy without HRT. Absolutely. Women have done it, but it's much harder.
Right. And it's a mix of over-the-counter nutrition and supplements, correct?
Yeah. I mean, sleep optimization, stress reduction, good nutrition, solid nutrition. Go read the Galveston Diet about that. And then, pharmacology.
Yeah. Okay.
And movement.
And when you say pharmacology, explain that.
Pharmacology could be hormone therapy or other pharmaceuticals that whatever we need to optimize your health.
Everything would fall under that umbrella of pharmacology. Okay. Yeah. Kim's and Lenore, there are a lot of supplements and vitamins out there that say, oh, this is going to treat your menopause, or this is going to treat some sort of symptom. I know that you are a big proponent. I think it's a particular fiber, but is there anything that we should be taking in addition? Let's say we do. I'm going to get pharmacology and HRT tomorrow if I can. But are there any other supplements and vitamins I should take?
If you are vitamin D deficient, it is such a crucial hormone in so many enzymatic processes in our body. So you need to ask for a vitamin D test when you go see your doctor, because of our gut health and we're avoiding the sun for good reasons. 80% of us will have a really big vitamin D deficiency. So that is one that I'm it's very safe, 4,000 IUs a day to supplement. Now, full disclosure, I am a doctor who created a supplement brand because it's hard. I was recommending all day long, and I'm go to this company because they test this, and so I did create supplements when I was counseling for nutrition, because most of my patients weren't getting enough fiber, were struggling to get fiber, and all had vitamin D deficiencies. So I've created some things. And it's not a one size fits all Band-Aid. Those are the two that I'm probably, you need to be tracking your fiber. If you're getting more than 30 grams of fiber per day, you're good. You don't need a supplement, but that's really hard for most women and the way our world is set up today. And so I'm often recommending a fiber supplement for them. But again, supplements don't take the place of good nutrition. So you can't swallow a bucket full of supplements and then, make poor choices and effects, think that you're doing anything positive.
Exactly.
So I like supplements to supplement a gap. Turmeric has some pretty good studies on osteoarthritis and arthritic pain, in females, especially they were done in animal models. But, so that is something I, recommend occasionally when my patients are having different arthritic kind of symptoms and their HRT is not really hitting it for them. They can try that. Turmeric teas, just most Americans don't cook with a lot of turmeric and have it in their diet naturally. So there's one particular collagen that's been studied in menopausal women for treatment of osteoporosis. I'm a big fan of that one. So when I have a patient coming in whose mom had osteo or she's really freaked out, and, that's one test. I don't think you should wait till 65 to get. I think you should pay out, if you have to pay out of pocket. And you can now find these DEXA scans in the bigger cities for $100. and go get your bone density done as early as possible and know what your baseline is. And so I have like a little osteoporosis prevention, recommendation sheet that I'm like, oral calcium, supplement has never been shown to decrease osteoporotic fracture. Neither has vitamin D. I never recommend calcium supplements. I'm like, you need to be getting calcium through your food. I forever, because of, American Board, I was telling, you need to take calcium supplements. It doesn't do a damn thing except give you constipation. So, for your health overall.
Which is why you need a fiber supplement.
You should be getting calcium. Yeah. Now you need the fiber supplement. You should be getting that calcium from food. So, just teaching people about nutrition, which is where I kind of started in this space, and how to track things and look at where are your gaps and how can you, improve that.
I would imagine the same mantra goes for anyone getting hormone replacement therapy or MHT. You still have to take care of your body. It's not gonna you still have
it's
to.
It's not a magic pill. I don't want anyone to think, oh, I just need some HRT and kick them out the door and off you go. It's like the GLP-1s, it's like giving someone Ozempic. You don't just, hopefully you're not just getting your GLP-1 agonist and just being kicked out the door and not followed and checking muscle mass. And are you getting adequate protein intake? This is a tool in your toolbox, but it doesn't work alone.
And we have 2 more questions and then we're going to wrap it up. Robin says, is there anything we can proactively do differently in the season than maybe we did in our 20s and 30s?
So I have this talk that I give, what would I tell my 25-year-old self, my 35-year-old self? And, at 35, I just had my second baby. I was still cute. I, was hanging out with my brothers all the time. And, and now at 55, 2 of those brothers have died from, cancer and chronic illness. My friends are divorcing, and I've totally changed my mindset. So one thing is nutrition over calories. Stop counting calories. Stop trying to be small. Make yourself big. Make yourself strong. So I'm strong over skinny. Move your body to be strong, not thin.
Okay.
The relentless pursuit of thinness is leading us to frailty and dementia as we age.
Wow. That's
you need to be an ass kicker. You need to be able to throw a toddler across the room. I mean, don't do that, but you need to be strong, because that's what's going to keep you out of the nursing home, keep you from falling, keep you functional as you age. Think about the next 30 years. Is the course that you're on, relentlessly counting calories and trying to be thin and low fat this and low whatever, is not serving you. And then educating yourself about menopause, and look at aging as a privilege. I am almost 56. I am living my best life. I am healthier. I am wealthier. I am more successful. I'm touching more women's lives at this age than I ever did at 35. And everything has led me to this point. But if I could go back and do things differently, I would have treated my health as something very, very precious and very, very different. I would have been lifting weights consistently and not giving a shit what I look like in a bikini.
Okay. I love that so much, especially as we're going into bikini season. This has been incredible. Last question for you. Sandy wants to know, some siblings experience it different. We may experience it different than our mother. Why is it worse for some women? And do genetics,
a huge part of it is genetics. Yeah.
Okay.
So the age at which you go through, and sometimes the severity of your symptoms, we think that a lot of that is genetically related. We know that certain ethnicities have different symptom profiles, where Asian women don't tend to have as many hot flashes. They have other symptoms. So, African-American women have terrible hot flashes, and they're much less likely to get care, to be offered HRT versus a Caucasian woman. I mean, there's so much disparity in how we understand this transition, what it does to a woman and how we treat it. It's very, very different, but genetics does play a huge part. Now, women who have a healthier nutritional profile tend to have less symptoms, like that. Your general health going into menopause will kind of set you up for having an easier time of it through the transition. But it's not 1-to-1. I know people with perfect nutrition, who got their asses kicked. And so, I don't want to make any woman who's suffering horribly feel bad and be like, no, I eat perfect, so it's not perfect, but we know there are trends based on nutrition.
It's like the difference between nature and nurture. Some of it is just it's going to be how you take care of yourself. And some of it is just like the gene pool.
Why does one identical twin get cancer and the other one doesn't?
Right.
So.
Well, Mary Claire, this has been just incredible. I love this book. As you write, it is the Bible of female midlife wellness. And I truly believe that. And kudos to you for living your best life. Truly, you're an inspiration to us. And I just feel so much better knowing that you're on the front lines of this fight for women. So
thank you.
God bless you. Thank you so much.
You're so welcome. Okay.
Okay, before we jump into my key takeaways and my pinpoint, I want to read a couple of comments that you have sent me. Suzanne said, I'm in perimenopause and I had no idea. I have so many of these symptoms. I just knew that I haven't felt like myself. That's from Suzanne. And Anne-Marie sent me this message. She said, I'm learning a lot. I'm realizing I'm not alone. My PCP told me I couldn't do anything about my weight gain because it's just genetics. And thank my parents. That was frustrating. She says, I'm on 2 different types of antidepressant and anxiety meds, and I can't enjoy the physical relationship that I once had with my husband. Thank you. I can't say it enough. Thank you for bringing women's health to the forefront and highlighting what needs to change. That's from Anne-Marie. Ladies and gentlemen, I know there are a lot of guys that are listening and watching this. Thank you for suggesting this series to me. Again, this show is everything that you want to talk about. We're talking about perimenopause and menopause and why we don't feel like ourselves because you asked me to talk about this. So this is so important. Thank you for the feedback. I cherish it. Okay, so my key takeaways. This is where you need to begin. You need to find a doctor. And I'll tell you a little bit about my journey. So, the first OB-GYN that I went to was like, oh, you're still having your period. You're fine. You're not in menopause. Basically brushed me off and dismissed me. I had since moved to another OB-GYN. And when I called this OB-GYN after my conversation with Dr. Haver, ready to ask those questions, they said that my OB-GYN had left the practice. So I was super frustrated, okay? And what Dr. Haver says, you want to find a doctor near you, and you can do that, a doctor who is trained in menopause. You have to go to menopause.org. Again, menopause.org. I did this. I found several doctors in my area, but personally, I didn't want to start all over again. So I went the telehealth, the telemedicine route. I'm going to link a couple that Dr. Haver recommend, but I went through Alloy Menopause, and these are doctors who are trained specifically in menopause. Within 3 days of my first contact, I had a treatment plan. A couple days later, I had hormone therapy on my doorstep delivered. I can't say enough good things about telehealth and telemedicine, but if you are going to go the traditional doctor route or go to your PCP or you're going to go to your OB-GYN or your endocrinologist or whomever, you need to ask these 2 questions. You need to ask, number 1, how much training do you have in menopause? Okay. And then number 2, how comfortable and how much training do you have in recommending hormone replacement therapy or menopause hormone therapy? Okay. So those 2 questions, how much training do you have in menopause and how much experience and training do you have in prescribing hormone replacement therapy? Okay. You need to make sure that your doctor is proficient in those 2. If not, go to menopause.org, find somebody that is trained in menopause. If that doesn't work, you can do the telehealth route, telemedicine route. Again, I love Alloy. I'm going to put a link in my show notes. I have a discount code too. But I love what Dr. Haver said, because how many times do we think, oh, I need to get my hormone levels checked, or I need to get a saliva test, or I need to get a blood test or a urine test? Well, guess what? Our hormone levels, as she said, are in chaos every single day. My hormone levels at 6 a.m. are going to be totally different than my hormone levels at 6 p.m. Those just aren't the regulatory standards anymore. Dr. Haver told me, we already know that you are extremely low on estrogen because you're in perimenopause or menopause. So we know right out of the gate, your levels of estrogen have significantly dropped. So with Alloy Menopause, this telehealth company that I'm using, they didn't do a blood test. They didn't do a urine test, saliva. And I even asked them about it. And they said, we're going to treat your symptoms. We already know you have low estrogen. Your hormone levels are in chaos. They're not going to tell us what we need to know. So we are going to treat your symptoms. And that's what they're doing. So I have been on a patch for, my gosh, I need to actually go back and look at a calendar. But it's been 4 to 5 months now, an estrogen patch. I have a cream for the Netherlands, and I also am taking progesterone, a pill at night. So that is my trifecta right now. And I check in with my doctor every month to tell her how I'm feeling. And if she needs to boost the dose, she'll boost the dose. If she needs to change it, she's going to change it. So again, where do you start? Menopause.org to find a doctor if you don't have one already. But make sure that your doctor, if you're going to go to your PCP, if you're going to go to your OB-GYN, that they are trained in menopause and they are comfortable and experienced in recommending and prescribing hormone replacement therapy. I thought what Dr. Haver said, that there is no test to determine where you are in the process, was really enlightening for me. But she did say that you can take an FSH test. Again, that's an FSH, like Frank, Sarah, Ham. Okay. Sorry. Terrible acronym. But FSH, only when you're nearing the end. That will tell you if you're nearing the end and approaching menopause, which again, the definition of menopause is 1 day. It is 12 months without a period. That is when you are menopausal, okay? You can ask your doctor for a vitamin D test. I asked my doctor a couple of weeks ago for a vitamin D test, and I realized I'm really low. So I am taking a vitamin D supplement as well. You can ask your doctor for blood tests to rule out disease, not for the hormone panels, because like she said, they're not going to do anything. But ask your doctor for blood tests to rule out disease, because so many of these autoimmune diseases or other diseases are because of the low levels of estrogen in our body. I think that's all. I told you guys I had a ton to kind of unload on you. Again, if you want to win the book, 5 copies of The New Menopause. This is like the Bible when it comes to menopause. You can win a copy of it if you are signed up for my personal newsletter. And if you want to buy some of my clothes from my past life and TV news, that sale is live. I'm going to link in my show notes. It'll be on my socials as well. Okay, so next week we are specifically tackling nutrition and exercise during these years. Our bodies have changed, so I've invited 2 people to the conversation. Dr. Jen Ashton, she's the former chief medical correspondent at ABC News, very tight. She has since left ABC News very recently and formed her own women's health company called Agenda, specifically focusing on menopause, nutrition, and weight management. The other guest is my husband, John. And he will reaffirm what I think we all know in the recesses of our brains, that they're not kicking us out of bed. Our partners really don't care what we look like, but I know we do, and we don't feel right, and we want to feel better. So John's going to bring that very important male perspective to the conversation. And it's all going to be centered around nutrition and exercise. And just to close the loop on this conversation with Dr. Haver, she said if she could go back and tell her young self anything different, she said, I would go back and do this differently. I'd have been lifting weights and not giving a crap what I looked like in a bikini. She says, stop trying to make yourself small, make yourself big, move your body to be strong, not thin. You need to be an ass kicker. You need to throw a toddler across the room. Okay, not really, but that's what we have to be doing. So we're really going to dive into the nutrition, the exercise next week as we wrap up the series on perimenopause and menopause with Dr. Jen Ashton and my husband, John. I think that's it. I'm rambling. We're going to keep talking about it, and I'll see you right here. And thanks for all the feedback. I love hearing from you guys. We'll keep talking about it. See you next week. Bye. I know you guys thought you were done with me, but not quite yet. I have one more thing to tell you about. If you're watching on YouTube or you're listening on your favorite podcast platform, don't forget to subscribe to the show. I don't want you to miss a single beat or a single conversation. And remember, my DMs are always open. Tell me what you want to talk about.